Hello, my name is Ahmed Geneid, and I'm really happy and thankful for the invitation to be here with you today in the UEP Voice Marathon, which is going to be covering a huge number of presentations, topics that are very important to us dealing with our voice, phoniatrics, and laryngology patients. I work here in Helsinki University Hospital, where you are all invited if you would like to come and follow of what we are doing here in our hospital and with our voice and swallowing patients. My topic today is on myoneurectomy for laryngeal dystonia and specifically for the adductor type of it, which is called adductor spasmodic dysphonia. I usually like to begin with the take home message, which is not um, a mistake with the arrangement of the slides, but it is rather to tell you the aim of this presentation. I would like, along with my colleague Tetsushi Sanuki, to convince you that myoneurectomy and thyroplasty 2 are both viable options for treatment of patients with adductor spasmodic dysphonia, offering them a possible way to get out of the roller coaster of Botox injections and to give them a permanent treatment. To begin with, spasmodic dysphonia is a rare localized dystonia that usually happens in some of the muscles of the larynx. It can happen in the thyroarytenoid, it can happen in the posterior cricoarytenoid, and usually it begins in middle age and it is more common among females. And the incidence is usually about 1 to 4 among each 100,000 inhabitants. So probably you will all have it in your countries and you are all dealing with it some way or another. When it comes to spasmodic dysphonia, there is usually a classification of it which depends on which muscle it is hitting. I mean, the dystonia. Is it hitting the thyroarytenoid? And in this situation, this is the most common type called adductor spasmodic dysphonia, affecting about 80% of our patients. Is it hitting the posterior cricoarytenoid? And in this situation, it is a much rarer form and called adductor spasmodic dysphonia. Or is it in both? And in this situation, it is a mixed type. Or is it going for the cricothyroid muscle? And that's what's called cricothyroid dystonia. The aim and the main idea here in this presentation is dealing with adductor spasmodic dysphonia hitting the thyroarytenoid type. And this is what we will be focusing on in the next few slides. So I will play a voice sample of a patient with adductor spasmodic dysphonia. You will notice that the patient, while he is talking, there are some instances of two pressed voice, which is the main thing or the main symptom in adductor spasmodic dysphonia. And also you will notice that when he is like having a singing like intonation, the voice gets much better. Let us listen to it.
Tuolla on Lasse. Hän on 5-vuotias. On lauantai-aamu ja koko Lassen perhe on kotona. Äiti, isä, Lasse itse, pikkusisko Liisa ja heidän kääpiökoiransa Kaappo. On lauantai-aamu ja koko Lassen perhe on kotona. Äiti, isä, Lasse itse, pikkusisko Liisa ja heidän kääpiökoiransa. He näyttävät paraikaa syövän aamuruokaa vuoteessa. Aamuruuan jälkeen Lasse menee loikoilemaan. Hän odottelee, että Nikke soittaisi ovikelloa.
So we usually deal with these patients by injecting botulinum toxin in the thyroarytenoid muscle. And what happens is that it simply works on cutting the connection between the nerve and the muscle fibers of the thyroarytenoid. And this usually doesn't happen immediately on the first day after you make the injection, but usually in about a couple of days. And it is not uncommon at all to see that these patients have some kind of roller coaster effect of Botox injections, in which 2 days there's still the Botox didn't work, and then for 1 or 2 weeks the voice is going to be quite breathy, and then the voice is going to be normal after that for a period that really depends on the amount that you have been injecting and depends on the symptoms of the patients as well. Let's say like about 3 to 6 months, and then the patient is going to come again. And that's why we call these patients as if they are our frequent flyers. They usually come back again, and some of them have been coming to us since the 19th of the last century. And because they keep on coming and because we keep on getting new patients, so if you come one day to visit us in our work, you will find that we have a huge number of patients coming every second Friday for our injections, and almost about 20 to 24 patients coming for Botox injections in our one day of Botox injection every second Friday. How we do it usually under AMG, but we also do it with the channel fibroscopes. I will not go through into the detail of that, but I'll just show you that when you do it under AMG, it is very quick and it goes like this. The patient is lying on his back. There is no need for anesthesia. You will palpate for the cricothyroid part here, which is between the cricoid cartilage and the thyroid cartilage, go through this cricothyroid, go into the thyroarytenoid, check for the EMG, and then have the injection being done. So it is as quite easy at that, and we usually do the injections on both sides for most of the patients with thyroarytenoid injection being done for adductor spasmodic dysphonia, as you're seeing here. However, there is a need for a surgical treatment because they keep on coming back and they keep on having this problem, and we simply would like to help our patients. And that's what takes us to the next slide, in which we think about what options do we have. There is, if you go through the literature, there are three options. I have here on the right side one of the options, and I will not be addressing it because simply I see that it, on the long term, it has many complications. So I don't think that it will be actually a real viable option on a huge prospect in the future, which is called selective denervation reinnervation. The two main options that are actually available are thyroplasty 2, which is a very nice idea. If you have, and if you look at my hands, if you have this cramping happening between both vocal folds, then you are trying to have probably a little bit of space between the two vocal folds anteriorly. And in this way, you can have more space between them and you can avoid the cramping that is happening, or actually listen the effect of the cramping that is happening between the vocal folds among patients with adductor spasmodic dysphonia. And the problem so far with this operation is that the titanium bridges that you can have between both vocal folds here in this place in the anterior commissure, they are not yet available outside Japan. But right now, and thanks to the work with Sanuki and all of the colleagues in Japan, we are having this hopefully in the next year to be offered in different places, mainly in Helsinki and also in London. And this is one option. It is not available yet, but it is very promising, and I see that it will be very viable in the future. Another option is to do something like Botox, but on a mechanical way. And instead of cutting the connection between the nerve and the muscle, let's take the thyroarytenoid nerve branch and let's take the thyroarytenoid muscle away. And this is what it is all about in this operation in myoneurectomy. And it deals with aiming only at the thyroarytenoid nerve branch and keeping all of the other nerves and the other nerve branches intact. So what we actually aim for in this operation is to keep the lateral cricoarytenoid muscle intact, which is moving the vocal folds. To keep the posterior cricoarytenoid muscle intact, we are only aiming here for the thyroarytenoid muscle and the nice branch that it goes to it. Is it a new operation? No, it has been used and reported in different countries. I would, among them, for example, say that we have Brazil, Belgium, South Korea, also Japan. And the fact that it is not new, but relatively new in comparison to thyroarytenoid, to thyroplasty 2, makes it very interesting because simply you can use it, especially because you don't have the titanium plates available for thyroplasty 2 yet. When I wanted to learn about that, I went to Ton Langveld in Holland, and I saw what he has been doing, and that's where I learned the operation from. And to tell you very quickly, This is from one of his slides in which he was presenting the effect of myoneurectomy. And you will see that in this phase, he had about 61 patients operated upon, 37 ended with permanent effect, but there is also the problem that some of them, within a period from 3 to 6 months, will have the nerve growing up again, finding a couple of muscle fibers, and causing again dystonia and spasmodic dystonia to the patient. And then you can operate on them again and again. And in the end, despite 3 operations being offered, you will find that some patients will still get the spasms back. And this is very important to consider here. Not all the patients will get help from this operation. Let's see one example of one of the operations and one of the patients operated. This is the video of the patient before the operation. What you see here is you see like normally moving vocal folds, everything looks usual. And why I'm showing this, because in spasmodic dysphonia, you won't expect, of course, anything unusual because it is more or less in terms of the cramping or the dystonic movement of the vocal folds going against each other. In the intraoperative situation, I usually remove part of the false vocal fold to give me vision. And then when I'm going inside intraoperatively, I already here removed, as you can see, the thyroarytenoid muscle. So it is not anymore there. I already checked for the nerve and cut it with monopolar. And usually there is a small nasty vessel that is going by the nerve, which is the reason we call it the neurovascular pedicle. And that's what I cut here. And what you see down there is the lateral cricoarytenoid muscle. You will also encounter a couple of blood vessels here, and it is excellent to deal with them with the monopolar. Kindly notice that when you go there, you're actually aiming at some point, as you see here, to have the lower part of the thyroid cartilage already being seen and palpated. And here in this patient, you see that the lateral cricoarytenoid muscle is still there. Here you see that the lower edge of the thyroid cartilage is there, and everything above that is removed, everything which means the thyroarytenoid muscle. And this is the little bit frightening situation that you would see intraoperatively at the end of the operation. I know it looks scary, and that's probably the reason why many are still not going for it. But if you check for the patient on the first day post-operatively, usually it will look like this. You will find that you have the part of the false vocal fold removed, you have the inner perichondrium shining to you, and you have that part of the thyroarytenoid muscle removed on both sides. When the patient come back to you after that, for a checkup after 2 months, sometimes you will find a smaller granuloma like what you have here in this patient on the right side. And this is nothing to be worried about. Why? Because it will simply disappear. Like if you check for the next slide here, this is the same patient coming after 6 months. And let us see how it looks like right now. So what you see here is that simply it looks as if nothing was done except that you know that the false vocal fold, the middle part of it is missing because you cut it away. And the nice thing is let's check for the movement and the vibrations. So excellent movement still intact, excellent vibration still intact. And this is the whole idea, to preserve them while to get rid of the spasm in the thyroarytenoid muscle. This is before and after of the same patient. And when you look at it, you see that, yes, the false vocal fold, most of it is missing, especially the middle part. and the vocal folds, they are still intact. Um, what should you be worried about? In my opinion, there are some precautions that you should bear in mind. You should be only doing this operation after you have seen it live, because it entails a number of issues that you would have to address, like using the monopolar in the best way, finding the neurovascular pedicle. It only works for patients with whom Botox will work. So if Botox doesn't work for one of the patients, then he is not or she is not a candidate for this operation. The Botox must work as a proof of concept that by cutting the connection, by cutting the nerve and the muscle fibers, you will have it working. Granuloma happens, and in all of the patients that I operated so far, only one that I had to remove the granuloma under local anesthesia. Only 60% will get permanent effect after the first operation. You can go up to three operations, and in this situation, this 60% is going to go up to about 80%. And please record the voice patients before the operation twice, when Botox is working and before Botox is working. And the aim is that you should be aiming to have an effect from the operation that is exactly like the best effect coming from the Botox. And that's what is called success in terms of giving patient a permanent Botox-like effect on her voice. Thank you, and I hope to answer your questions. Thanks a lot.